there's probably nothing more important in our lives than occlusion. If you were a dentist and you were a patient, there'd be nothing more important in your lives than quality of life and comfort. And those two aren't necessarily related, despite everything we've taught. So we have this ultimate responsibility to try to improve the quality of lives, but at the same time, to be burdened this need to maintain some level of occlusion that we thought was ideal. And at the same time, what we know is that people with anti-open bites don't have aesthetic problems. It's not that you walk down the street and you see people with open bites. It's horrible. The biggest problem with anterior open bites isn't you or your patient. Most of the time, it's the other doctors who are seeing that patient who advise them how potentially troublesome this could be. You don't have much of a leg to stand on if the patient didn't have any signs or symptoms to begin with. Then the punishment's been worse than the crime. But if the punishment is significant, we're less concerned about an anterior open bite. The bottom line is that we don't know what causes them. There's all kinds of theories. We've looked hard at neck and neck changes, and I think it has to do with posterior cranial rotation, but that's a whole other story. What we do know is that it's typically not what we think of in terms of super eruption, and we cover that in depth when we're in London and Sheffield. We'll cover that in depth, and you'll have a better understanding. And it always does concern me with people putting in appliances who don't truly understand appropriate designs, appropriate decision making, and make generalizations about therefore what they see and what they do, and how dangerous they can be without appreciating how incredibly powerful appropriate design can be for our fear. And don't get me wrong, that fear is justified because it's ingrained in us and it's ingrained in those people around us. And I have many a patient walk in my office and they're laughing about, how upset their doctor got when they looked at their mouth and they said, yeah, but you don't understand how I feel, etc. So it's really, really common, a common concern, and probably the number one issue with appliance design. So what we teach is not only the design to minimize this likelihood, but we teach how to prevent it, how to determine when it's most likely to occur, and how to make a decision, or what we call an appropriate risk-benefit decision. How to make that decision so that you can decide, and with your patient as an understanding, and you're together deciding what is it you have to risk, what is it you have to gain. This risk-benefit decision, guys, is no different than it is when you place a restoration, or when you prescribe a medication as a physician for migraine, or when you do anything, prosthesis, or for therapy that has the potential for untoward effect. You're making a risk-benefit decision. The problem with this particular risk-benefit decision, I'm watching this, really having trouble loading, Matt. Okay. I have but we don't need it. The problem with a risk-benefit decision here is that when you're making a risk-benefit decision, you need input. You need information in to get information out. So the information in is, what are my risks and what are my potential benefits? And then the information out is the decision based on that quotient. Now here's the problem. If our bias is so strong having to do with occlusion, or our fear is so strong having to deal with occlusion, then the occlusal issues in terms of risks get overstated. The person who can lose is the patient, because the number of patients that we've helped that wouldn't have been helped because of my fear of what I might do and etc. It would be criminal, and I consider that, in fact, criminal today. I consider the number of people that I know we can help in massive ways that don't get help because of the fear that you and I have, and for good reason, because we were taught to have it, because occlusion was ingrained in us. So a lot of the time that we spend when we meet and we teach is to talk about occlusion. And what's fascinating about occlusion is that a lot of people have heard me, and Matt's going to laugh at this. A lot of people have heard me have said that Glassman says occlusion doesn't matter. And I want to make it clear that, of course, that's the most ridiculous thing that anybody could ever say. Of course, occlusion matters. You and I have seen it. You and I have adjusted appliances, adjusted patients' teeth, and seen immediate, significant changes. So to say that occlusion doesn't matter is, of course, absurd. I need us to add a word to that question whenever we ask it. And the word is when. The occlusion matters when. The adjustment that I made has an effect when. How did it have that effect? Well, it took pressure off the tooth. Really? When? And so when we ask the question when and then we look carefully at tooth contact and add that question when, we start to get into some really interesting questions. Do teeth touch when we swallow? Do they touch when we eat? Do they touch when you're walking down the street? Is Matt sitting there with that weird hair on his face? But while he's sitting there, are his teeth together? Should they be? What happens if they are? Then the adjustment that you made would be effective in Matt right this moment. But for the majority of people, it shouldn't be. And if it is the problem where they're touching or that they're touching? And when we adjust, do we stop the touching or do we alter the effect of the touching? And so when we start asking those kinds of what I consider to be intelligent questions, we start getting out of what we call the stipulation of occlusion. And this also isn't our fault. We stipulate occlusion. We do it. If I give you an upper minor and a lower minor, the thing you're going to do is put them together and see what happens. The masseter and temporalis go into permanent contraction and stay that way, even though it never happens in function, ever, with any intensity or duration. And yet, that's how we think. We think of cusp tips in fosses. We have an entire profession, especially of our profession, whose goal is to create ideal occlusion. To me, that doesn't make sense. There is no such thing as an ideal occlusion. An ideal occlusion is one that never comes together. It never happens. So when we are perfecting occlusions, are we perfecting them for function? Or are we perfecting them for parafunction? And that's the key. See, so that so it's not that we don't understand that occlusion matters. We start looking at when and how, and we start making it inappropriate assumptions. Unfortunately, what's happened over the years is that we've looked at occlusion and we've taken some very empirical evidence and accepted it as real. In 1961, Ranford and Ash determined that people grind and clench their teeth because of these little white spots that are interferences that are there. There was no evidence of that ever, and it's never been shown. In fact, the opposite indeed has been shown. That interferences cause hypofunction, not hyperfunction, but we go through that as well. We use the science so that we can perfect our art. But unfortunately, dentistry over the years hasn't paid much attention to science, and much of the science is kind of passed down and become part of our folklore and become part of what we live with every day. And what we've learned, and this is why I really want you to consider coming to see us. What we've learned isn't that, well, I'm going to go to a 2-day lecture and I'm going to learn how to treat TMD, or I'm going to learn how to treat joints or muscles, and you know what, I really don't want to learn that, so why would I go? I get that. I don't think you should necessarily be the ones, if you choose not to treat orofacial pain and joint dysfunction. That's not why you're coming. What we've learned is that some of the hoops, some of the things we've been taught that are so essential in dentistry that we must accomplish or else we fail when it comes to occlusion are not valid. And that once you understand what is valid and what matters, and you begin to understand adaptive capacity for patients, and you begin to say, well, you know, maybe the less than ideal occlusions aren't causing all of the pain that we think it is, because after all, did I lose you?
No.
Are we good?
Yeah, all good.
Okay. Because after all, um, if you look at your asymptomatic population, what you're going to find is a great percentage of them don't have ideal occlusions. So it's really hard to blame a patient's pain on crossbite when 50, 60, 70, 80% of the patients with crossbite don't have any pain. Are you telling me, Barry, then that crossbite can't play a role? I'm telling you that crossbite can change the way the teeth touch when they're not supposed to touch, and therefore that existing occlusal scheme can be contributing to the pain pattern. And altering that scheme, not necessarily correcting the crossbite, may result in a significant improvement in the afferent nociception for that patient, and consequently their pain pattern. You mean we can make a change and not put the patient through 2 years of orthodontic care? Absolutely. And we'll give you a whole series of articles from Rinchhouse that makes that point over and over and over again. That is so that some of the assumptions that we've made over the years have really hurt us, have really made dentistry maybe easier for some of us mentally, because we think, well, now I've got a cookbook and now I can follow this cookbook. But in reality, that's made it more difficult for us, because it's sent us on some bad paths, and it's helped us, it's prevented us from finding out the potential cause for some pain, making the assumption that it was occlusion, etc., etc. And more than that, it's done something that I think, and we'll spend a lot of time with this as well. It's done something that really concerns me. The most significant pain patterns that we deal with, aren't trigeminal neuralgia or trigeminal persistent peripheral trigeminal neuropathy, or facial pain patterns, or atypical facial pain, or stylomandibular ligament insertion tendinosis, or temporomandibular joint arthralgia, or disc displacements, and we go over all this. But that's not they're not our sickest patients, and you'll know that you'll agree with this. Think about the patients that you deal with that are what we call have occlusal dysesthesia. You may know it by another name. I've known it for years for the name of a positive occlusal sense. You may affectionately refer to these people as occlusal neurotics. The ones who say, you know, I just can't get comfortable. My bite's just not comfortable. Can't you just adjust it here? That's better, doc. Yeah, that's better. Oh, whoa. Now it's up here. Can you adjust it here? And we start chasing comfort. Patients aren't born with this awareness of occlusion. It's not genetic. It's given to them by us, by our profession. And where did we get it? It was given to us in dental school. So we are taught about occlusion and its importance, and we then pass that message verbally and non-verbally to our patients over the years, to the point where they know just how important that bite is. And then something goes wrong and they become aware of that bite, They become aware of that bite. And now what should be involuntary becomes voluntary. And you and I both know that you don't bite the same every time. There's fluid in the joints. There's muscles that control it. I always laugh. I sometimes wonder about these people that spend hours to perfect the occlusion and look at all the dots and see all the tripoded dots and how wonderful it is. And I just want to say, really? Sit the patient up and have them close. Have them swallow and test it again. This isn't a hinge like articulator. And so there is no such thing as an ideal occlusion. Oh, that's really scary. Gosh. There is no such thing as an ideal occlusion per se. We've got patients with ideal occlusions in lots of pain and patients with horrendous occlusions, and you know this. That you ask them, how do you feel? They say, great. We do a lot of sleep medicine, and we put in oral appliances that sometimes will create posterior open buds. And you have to ask yourself, really, they can't get their back teeth together? They must have trouble eating. Ask them what they had for dinner last night. Never a problem. So what's that about? So we need to, what we're saying is, what we need to do is put occlusion into its proper perspective and understand that it can play a role in dental pain, odontogenic pain. It can play a role in tooth loss. It can play a role in implant failure. It can play a role in facial pain. It can play a role in trigeminal neuropathic pain patterns. It can play a role in sympathetically maintained pain patterns. It can play a role in all those things. It's not the cause. It's a contributing factor. And it can be considered, and it's something that we should be able to consider, but at the same time, not overemphasize to the point that we create occlusal neurotics. So looking at occlusal dysesthesia, how to treat that patient, how to deal with that patient that says to you, Dr. Bergen, I just can't get comfortable with my bite. Why, that's the last person in the world you want to start adjusting their bite. Because now you own their comfort, and the reality is that their comfort isn't based upon how their teeth are touching. It's that they're touching, and that they're concerned about their touching. So looking at occlusal dysesthesia then becomes a really critical issue. So let's look at some of the things then that we'll talk about at the conference. One, we will do what we call a practical review of anatomy, because I think it's really important that we as dentists understand the joint. What is it that concerns us most and that scares us most? Is that which we don't understand? And the problem with temporomandibular joint problems is that we're not very well trained. It's not that we're not capable of being trained. It's not that it's all that difficult, but we're not well trained. And so when a patient comes to us with a joint click or a joint pain, and we're not, it concerns us. And we'll either send them off and say, well, the click doesn't matter, don't worry about it, or make a bigger deal than it should and start the patient down a road of either toward occlusal dysesthesia or toward excessive treatment that may not be necessary. So if I'm, I sure wouldn't want to go to a foot doctor who didn't know how he walked, and I sure don't like thinking about going to dentistry or dentists who don't know much about how the joint functions and how we chew and how teeth contact reality is. Somewhere in the middle of my career, my wife turned to me and asked me about a chewing pattern and how teeth contacted when we chewed, and I didn't have an answer. And I had been treating temporomandibular joint issues for 5 or 6 years before I began to gain a comprehension, because it was an attempt to, I don't know, to make it more complicated than it was or whatever, but some of the gurus were never teaching the basic anatomy that isn't all that difficult. It helps us so understand, so that we can explain in lay person's terms simply why we should be concerned about that patient's click, or maybe why not, and whether we should or not. And that becomes really important from our standpoint, from your standpoint of view, so that we're not in the dark. Patient comes to us and they're clicking, and the mother's concerned the braces just came off. And the mother says, so tell me, is this a problem? What do we say? Should I go back to my orthodontist? What do we say? If we say yes, what does that say to the patient? What message is that sending? Well, it's the orthodontist's fault. And if the orthodontics were done correctly, that clicking wouldn't be taking place. You and I both know that is most likely not the case. So why does it happen sometimes after orthodontics? And we go into that. We'll explain that. So we'll look at the very practical nature of joints and joint function to enlighten us all, to make us feel better about answering those questions, and be able to make more informed decisions as to what treatment's required, keeping in mind the goal is always to diagnose as well as possible, while doing the least we have to do to make them better. This has been a problem in our field for a long time. For many, many years, we've had these TMJ gurus, and they've come up with treatment plans, and I happen to know that there in England, there's large societies of people who are learning from what I call the structuralists, the ones that are talking about how the jaw's got to be moved downward and forward, and the head's got to be on the neck and shoulders properly, and that's all determined on jaw position, which is all determined by tooth position. So if we change the teeth, we change the head and neck, and we change the blood flow, and we increase brain supply and eliminate head, neck pain and shoulder pain and testicular cancer. I mean, I've heard all of it, and none of that is evidence-based, and some of it comes from the fact that some changes have been made over the years. We observed the change in symptoms, and then we constructed a mechanism that was a very complicated one and involves a lot of treatment. Here's the good news for you in general dentistry. That's often not necessary, and usually not necessary, and we can accomplish many of the same goals much easier, with much less effort, with much fewer risks. It's just less treatment, and it should be done in dental office and around the country. Every dental office should be available. I should have some basic knowledge of joints. It shouldn't be. We shouldn't be in the dark about that. And to understand that muscles themselves are not usually the source of the problem. Muscles are overrated. Muscle spasms don't occur for the most part. The lateral tergoid doesn't go into spasm, as we've been taught for years. And all of the signs and symptoms can be explained in a much more concise, less overwhelming way. That we as general dentists, we're smart people, but we've been led down a path that almost blocks us from wanting to treat this disease called TMD. If I were king, there would be no such term as TMD. It doesn't mean anything. You're all familiar with that by now, I'm sure. But the public isn't, and our fellow physicians aren't aware of that, and unfortunately, insurance companies aren't aware of that. And so there are insurance companies here in the United States that make exclusions for TMD. I still, they say, well, I can't be seen by you, Dr. Barry, because you treat TMD. And so the term TMD never appears, not because it's insurance, because it's non-descriptive. It doesn't help us. It's like treating all the patients who have knee problems the same way because they've got knee, as opposed to disc issues or pterygoid tear. I mean, a collateral ligament. So, looking at this and understanding the various diagnoses in TMD that really are valid as opposed to the term TMD at all, understanding in some perspective what role we can play in headache, and not suggesting that we treat headaches or that we become the primary care headache treater in headaches, or that the neurologists don't know what they're doing and clear there we should take over. And I mean, I've heard it all. Of course, none of that's valid or accurate or going to help you. Our goal is to help our patients, and at the same time understand that something of model that we've learned in dentistry, and that is another major issue that we tackle in the course. And we'll tackle the reason that many dentists will tell me how wonderful and happy and wonderful this profession is, and how happy they are in it. And in short order, I start hearing all of the complaints and concerns about staff and patients and the problems and the difficulties, the expectations, the reimbursements, etc. This is a very difficult profession. We all know that. And there are lots of pitfalls that we attempt to protect ourselves from, to keep our motivation positive, to keep our eye on the target of patient care, and yet a lot of people pulling at us to make that very, very, very difficult. And recognizing the difficulty is part of it. I didn't recognize it in dentistry. I was as blind to my own unhappiness, and as blind to my own frustrations, and protected myself ways that I found many dentists do, in fact. And because I was still striving for some level of perfection, like perfecting an occlusion, like a perfect appliance, like a perfect veneer, like a perfect bridge. And I was going for perfection day after day after day, patient after patient after patient, knowing that sometimes I reached it. But unless I closed my eyes and squinted, I didn't reach it all the time. So I had my choice. I could close my eyes and squint, or I could accept that I was no better than the science and I was doing the best I could. Nobody can do that in dentistry. You can't. That's not acceptable. And so you squint. And then you move into some pain and dysfunction, like I did. And you start treating headaches. And if you think that treating teeth is difficult in terms of trying to reach perfection, take a migraine patient that has failed medicine. Do I really think that I'm going to see them and put in my magic piece of plastic and suddenly make them better? The answer is no, of course not. So once I realized that I couldn't be perfect in medicine, and that no physician is, I began to appreciate that I wasn't perfect in dentistry, and that was okay too, as long as I continued to do my best. I think that moving into pain and dysfunction has taught me a lot about dentistry and dentists. And I've real concern about my profession and about the mental state of my colleagues. And so we address that directly, because you can't begin to treat some of these other issues if you don't. And what we've learned is that once you've addressed that, it helps you a lot in dealing with dentistry itself. Yes, anterior midpoint stops are a major part of our therapy. And they're a major part of our therapy because we accept that what we were talking about is learning how to protect our patients from the forces that can destroy the dentistry we've done for them, as well as destroy them themselves physiologically or physically. And that the good news is that those forces don't tend to occur during function. So we go deeply into function, and we show you the swallow, and we show you how people talk, and we show you, and we look at the forces into the central nervous system via EMGs, and look at EMGs, and we look at how muscles function, because it's the muscles that are placing the force into the cranial-mandibular system. So why don't we describe the system so you understand the joints, the muscles, the ligaments, the trigeminal innervation, both sympathetic and parasympathetic, and we go through that, and the role of teeth and what role teeth play in that, and then we go through function and what happens to that system during function, and then we go through parafunction and what happens to that system in parafunction. And the good news is that we learn very quickly that while function can play a role, listen, there are patients who say, I don't have any pain in my joints until I chew. Function can play a role. No one says it can't. Of course it can. But what set that joint up is usually parafunction, because most systems function is well within their adaptive capacity. So we go through the adaptive capacity of each of the structures, the joints, the ligaments, the muscles, the teeth. Teeth have various adaptive capacities, and that can be affected by acid and pH levels and hydroxyapatite construction and genetics, etc. And we all know that. So, but that affects the adaptive capacity of the ability of the tooth to deal with the forces that are applied in function and parafunction. So we go through all that, and we show why we've chosen the design of anterior midpoint stop. We talk about the potential side effects of and making intelligent decisions, so that we're on board with patients. And there's no yes, I agree. If you don't understand the potential, you don't discuss it with the patient, and the patient's not on board with you, putting in an anterior midpoint stop appliance on a patient with a limited overbite or overjet, especially overbite, is dangerous from your point of view, possibly altering that occlusion, leading to an anterior open bite that no one was prepared for, and that was worse, creates a situation that in the patient's mind is worse than what they were dealing with to begin with. Nah, who would suggest that? So most of the complaints that I get, or the concerns that I get about anterior open bite, aren't from people who have trained with us, aren't from people who have learned how to deal with midpoint stop appliances, are people who take an SCI out of the box and put it in and say, wear it. And I'll see you in a month. Well, they'd never do that. You never would do that. So so all that becomes an issue and is carefully reviewed. Yes, then we do go over orofacial pain patterns. We'll go over headache, and we'll go over classifications, and we'll help explain which ones and we can help, etc. That's on day one is we spend an awful lot of time on the anatomy and on general dentistry. On day two, we'll go into, for a half day, we go into the TMD, or about a third of the day, go into more of the TMD aspects, more of the orofacial pain patterns, etc., and the role. And then we do some hands-on appliance therapy where we put appliances in. I know that in London, Matt, correct me if I'm wrong, I'm going to get you on here in a minute.
Yep.
In London, we do have a patient that had contacted us and really wanted to come see me in the States, but we encouraged them to hold off and fill out some forms, and we'll do a history and do an examination, and hopefully put an appliance in a bona fide pain patient while we're in London. He's coming to Sheffield. Okay, great. Thanks, man. So
he's from up north somewhere, so he's going to go to Sheffield.
Okay. So if there was but for any of you in London, if there are any of you that have a headache pattern or facial pain or joint discomfort, and you're attending the course, I sure would appreciate if you let Matt know, and we'll get you forms and do the same thing for you that we're going to do for this fellow in Sheffield, and you'll get to see an interview and a comprehensive examination. We do go over that comprehensive examination. We show why we palpate muscles, which muscles we palpate, how meaningful or frankly meaningless most of the time that is. But when combined with the history and with the dental status in terms of wear patterns, we get a lot of information. So, and then of course, at the end of the day too, we put appliances in on each other with Matt and myself and Neil, and sometimes Matt has some very talented lab people there working with you to guide you in the design. Certainly, just putting an appliance in without understanding the design and understanding the many times the patient will come to me, and this is the truth, they'll come to me and they'll say, you know, I've had all these appliances and none of them ever worked. I've seen lots of dentists. The most recent appliance was an NTI, and it's not any better. And I look and I see this NTI is, you know, a standard NTI kit. It's an upper NTI. We've got canine contact. We've got excessive vertical, or getting locked out behind it. I mean, there's tons of things wrong with it. And yet, so as not to discourage or be negative about the existing dentist, we'll turn around and make them a mandibular B-splint, which Matt can do for you. And it looks like a different design, but of course it has the same mechanism built into it. It's just properly done. And this way we're able to get an appliance in that has a better chance of helping them without being suggesting that first appliance was any different than any other appliances and not well done. So we'll go over B-splints, we'll go over NTI upper design, lower design, why we do what we do, etc. in depth on the second day. So wow. So who needs PowerPoint? Right. So the review of the 2 days. I hope this has been somewhat helpful. Matt's just put in a Matt. Is that for the course? Do you want to come up? How do you want
to? Sorry, that's a link to the B-splint.
Oh, okay. Great. So we're in listen only mode. So if there are any questions, I'll before we bring Matt back up, and you have any questions for me, you can type. Have there been any questions up to this point? No, I don't think so. Oh, you guys are great. You know, we do a webinar in the United States, and I can't possibly get through the webinar because of all the, you know, you don't even get started, and there's tons of diversions and questions. People often ask me, why do you go back to London every year? I said, because I love those people. They're fabulous, and I can't wait to get back and be there again for the 2 days in London and the 2 days in Sheffield. While I work tail off, and my wife enjoys her favorite city. Questions, anybody? Anyone have anything for us?
Any questions? Barry, do you want to shall I take it off listen only mode and see if anyone wants to speak to us?
Well, if they want to, let them. Can we start by typing, because that's a lot easier. Okay. You see, it's really hard to communicate to get the back and forth. There's a little bit of a delay. So if someone has a question, or if they would like to get in and ask it online, certainly we can do that if they indicate it. But is there any question about either about the course timing, the course place, or anything we just discussed for the last 45 minutes? So we're getting some.
Yeah, we had some questions coming through. So we answered Robert Jacobs' question, which was the patient clenching and grinding at night as an anterior open bite. Is the SCI advised in these cases, or will it worsen the ALB? I think you answered that one. Okay. Charlene.
Well, the answer is that we don't.
Sorry, Barry, go on. I'll answer the question too.
Okay, great. The question is, will it make it worse? The first question is, first, you know, without being obnoxious, to know that we can get anterior open bites without appliance therapy. Certainly, they tend to occur after use of anterior midpoint stop appliances, and and I can't answer whether they're going to get worse or not because I can't answer whether we're not even sure of the cause. I have my own theories about them, and I'll review those theories. Again, we need to monitor them so that I've had patients that have large anterior open bites, and their biggest fear is that when they come, I'm going to take away their appliance. So at the same time, continuing to wear one certainly won't make it get better. And so we need to evaluate, is it helping our patient, and do they want to continue to wear it, and is that risk a valid one? There is a design that we use in those situations with open bite, with minimal open bite, and we call it dual arch snore hook. And we will show you that. What it does is it not only provides anterior midpoint stop, but it also provides slight anterior repositioning of the mandible at night. We came to realize that we never get anterior open bite with sleep appliances. We only get posterior open bite. So if we create this to act like a mandibular advancement splint, while at the same time providing anterior midpoint stop, and at the same time being more comfortable than most of the advancement splits, especially for our patients in pain, we may be able to avoid the development of the anterior open bite, or making it worse by moving to this design. It's very exciting. We have never seen anterior open bite get worse or develop when we started with this design. It's a little more complex to wear, but it's certainly not difficult. Okay, so how do you feel about the class Michigan splints for these patients? Yeah, I see that. So how do I feel about the classic design Michigan splints for these patients that I've described as occlusal neurotics? It's not the splint design that matters. The classic neurotic, you can't, only with appliance therapy. No matter what, the fact is that their teeth will come together no matter how, what appliance you give them. We don't want any posterior contact because that drives them, they'll alter that and become aware of that posterior bite. So our design is, for our severe neurotics, we put them in SCIs at night and what we call maxillary anterior passive appliance during the day, which do not allow the back teeth to touch during the day. It just doesn't protect in all the excursions, which they're not going to go through daytime. It's a clear appliance. It's doesn't affect their speech. Doesn't affect. It looks like they're wearing a small piece of Invisalign in their or Smile line. God bless me. In their anterior teeth. And in combination with, and they need to see our clinical psychologists. I mean, they just need to see them. Now, in some cases, we've gotten through it without them, but the reality is that we need to get the patient's head out of their teeth. We've put it there, not you, but our profession has. And so it's not a Michigan design. It is putting any piece of plastic between the teeth to help some patients. It might. I find that they find the occlusion on the Michigan appliance or any posterior contact appliance the same way as they find it on their teeth. Does that help, Ellie? The patient develops, then when we move it, can the AO be closed, Lester? So we've been asked 3 questions, and 2 have to do with anterior open bite. I haven't seen. I've seen some closed. I've seen some not closed, and I wouldn't. For those people who are over concerned about anterior open bite after we do the description and the understanding, and we explain risk factors, and we go through depths of patients, and we can't get by that, I'd say don't use an SCI. It's that simple. Or certainly don't use an SCI on a patient with a minimum overbite to begin with, because that's the only time you're going to get an anterior open bite. It's fascinating, isn't it? You can have a 6 millimeter deep bite, turn it into a 3 millimeter deep bite. Has the occlusion changed? Yup. Does anybody concerned about the open bite? No, they think you've improved the occlusion. Look at this, my bite's better. But it's changed. It used to be 6, now it's 3. So it's only a problem when the patient goes into closure and they can't and they can't get their front teeth together. And when does that actually affect the patient? Eating pizza, biting thread. When they look at that, if in fact at the same time they're waking up without migraine. So I have seen, Lester, I've seen some changes, some improvements, and I've seen some people come back all the way to normal, taking out the appliance. On other patients, my patients don't seem to want to get their appliances out. I'm seeing sicker patients. Okay, Lester, if that answers your question, I appreciate it. Let me know. Anybody else have one? And great, thanks, Les. Hope to meet you. I do look forward to coming. I will, when I get there, we do 2 days, and we always arrange to do something. That evening, my wife knows that on the Friday night, or I guess it's are we Tuesday and Wednesday in London? Is that right, Matt?
Monday, Tuesday. So we're doing 27th and 28th of October, which is Monday, Tuesday. So I think obviously Monday night will be a good night to go social.
Okay. Okay. So we're doing Monday, Tuesday.
Yeah.
Wow. Do I get in? Do I get in Sunday? That's going to be tough. I'll pull.
You'll do it. Right. And then Sheffield's a Friday, Saturday.
Oh, okay.
And the Saturday is going to be based in a lab here and then the facility in Sheffield. Day one is going to be in a. Right.
Okay. If anybody has any Provigil or uppers for Monday in London, that'd be appreciated. That'd be great.
I think it'll be good.
It's crazy. Yeah, I'll be fine. Anybody else? Cool. Matt, you got anything? You want to take over?
No questions. What I will say again is I'll just paste this in again. Again, a few more. There's a link there to Barry's events. If you want to read a bit more about the events, about the day 1 and day 2, a bit more right up on our website. What we're planning to do is, any of you that have listened in today, we're going to do a very, very exclusive offer for you guys. I don't want to say it publicly at the minute, but if you give us a call this afternoon, we can get you booked on that, and we'll give you a very, very very good discount on the courses. Day 1 and
so
day
you have the names of the people. You have the names of the people who have suffered through this hour. Thank you all, by the way. And they're the ones that will get that discount. That's cool.
That's
great.
Right. So,
and again, if there's anyone in London that would that has any particular complaints concerning their own either joint function, or would like an appliance for any pain issue, anything, whether it be headache, whether it be soreness in muscle, joint, facial pain, neck pain, whatever it is, if you're attending and you have that, would like to go through an exam and be the patient, that'd be great. We'd love, really would appreciate that.
Yeah, and equally, I think we've done it in the past where you can bring a patient along as well if you wish.
Okay.
Yeah.
Okay. All right.
Yeah, but obviously we'd like to know that beforehand, like we did last time, Barry. So you can get. We only need one patient, really, don't we? We don't want hordes of patients coming in.
Right.
But
Right.
If we had one patient, we can get questionnaires done. Barry has some questionnaires that we get you to fill in, and then we can do a patient exam, and get the patient fitted up with a device as well.
Great. Okay.
Great stuff.
I think that that does it for us. Okay. Thanks, everybody. I look forward to London, and enjoy the rest of your day. Thanks, Matt. Good talking to you. Oh, wait, we got some people typing. Just 1 second.
Okay, sure.
Great. Thank you. Thanks, David. I appreciate you spending an hour with us. I really do. It's encouraging, and I think we have a lot to offer this profession. I think our goal. I think we've been forced to make things much more complicated than they are, and you and I know that. and but no one's. It's almost like the emperor's new clothes. Nobody wants to say it out loud. I've been known to say it out loud, so we'll say it out loud. We'll say it out loud in London.
We've had this recorded, so we'll put a link on our website. Buddy. We'll send it to you guys, so you can see watch it again.
Very good. All right.
Okay.
Have a good day, everybody.
Nice room, Barry.
Thanks.
Right. See you soon. Right, we're going to end this meeting now. Thanks ever so much for attending, and we'll speak soon.